not the patient, as I think this morning somebody was mentioning. It is the physicians who are the barrier for the telehealth. If we can make it simple for them, make it easy for them, I think we can bring the technology to the telehealth to the mainstream. So with that, again, you can see number of published, information about how telehealth can solve some of the problems and so on. I'm going to skip all this. With that, basically what I'm saying is two things I wanted to just basically bring to your attention. One is, in order to solve healthcare problems, in order to bring the low-cost healthcare delivery, if we can focus on efficiencies of the healthcare workers, including physicians, and focus on changing the behavior of the population, I think we can really effectively deliver the healthcare. Thank you.
Okay, thank you, Mr. Krishna Gadrola. We'll take up the questions at the end of the sessions. So now I invite the next speaker from the Ramaya Medical College, Bangalore, Dr. Nandakumar.
Good afternoon. Actually, it's a privilege to be in front of you, and I come from an academic background. So, over the last 10 years, we have seen telehealth, e-medicine, e-health, and I had the privilege of working with Satyamurthy on getting these guidelines for India, that is, role of ICT for primary healthcare. If you can access even today, the report is as relevant as it was earlier. And what I am seeing, because like it has been a growth. I was a postgraduate, I finished a couple of degrees, and today standing in this room listening to similar presentations. Problem is, like, technology has never been a problem. Technology has proven beyond reasonable doubt that it can deliver. Only thing is, the number of companies what I am seeing has increased. Earlier there were one or two which were there. Today that has increased probably. So what is the moot question is, like, we have yesterday's diseases which needs to be treated in today's context with tomorrow's technology. How do we do it? Because the prescriptive form of answers seldom work in real life. We have isolated examples of excellence. So there is a pilot model which was done in Amethi. I was a part of it. I present. I got the first prize in my PG presentation. But is it working today after 4 years? Sadly, not to the extent what we had expected. So towards that end, for a country like India, where the ground realities are very similar to the video what he showed, and that reality would exist elsewhere. And taking from what Krishna told, diseases, if there is anything which is truly global, it is diseases. Tuberculosis in America is same as tuberculosis in India. Point. The question is, how do we identify them? How do we treat them, and how do we make use of this technology today that is available to us, and probably which will be improved in the next 5 years, to make the cure less painful than the disease itself. So with that premise, I'll be starting my presentation, wherein we are looking at this concept of teaching hospitals. This is a very pragmatic kind of a thing, like probably some of you might feel it as pedagogic, because I'm from a teaching background, not commercializing or marketing the concept. It's more of a realistic thing. In India, this is the situation. Can we use this as one of the models? Because there can't be a single model which can be a panacea or a universal solution. So we are looking at teaching college hospitals in India which have the requisite infrastructure thanks to MCI. Whatever be the thing, we have a stringent guidelines. These many specialties should be there. These many tables should be there. Forget about the patients. These many tables should be there. So that kind of a mode, can we use this already available thing with the current technology of the latest thing, whatever the models that have been put, and deliver the healthcare. So with that, what is the background with which we are proposing this model? A lot of thought has gone into it, and will it be a viable, cost-effective model? Because any model, for it to be successful, it should be sustainable and replicable. So it just cannot be working in isolation. So for that reason, we are looking at 375 plus hospitals, probably another 25 making it as 400 coming in, and the mandatory rural field practice training area. 100% any medical college, if it is open in India, it should have a rural training area. Even in an urban place like Bangalore, we need to adopt a rural primary health center. That is the mandate by the MCI. So which means that automatically your background requirement is filled. Because the Pareto, what most of us speak of, the 20% and the 80% distribution, is still going to be there even if it is 30-70. Doctors would be in cities and patients will be in rural areas. So this thing is always there. Thirdly, the PHC or the Taluka hospitals are either fully owned by the medical colleges with administrative control whatsoever, or they will be having to be adopted by the medical colleges, and there will be extension of super specialty services, and whatever the tertiary care that is being provided within the teaching hospital, can it be extended to the rural area also? So that is what we are going to try to look at in the next 5 or 6 minutes. So what are the advantages within the medical institutions which sort of like put it at a pivotal role in this whole model is availability of basic infrastructure at the remote end. Because I am specifically focusing on the tele kind of a linkage between the corporate hospital, the teaching hospital and the primary health center. At the primary health center, if you have 20 interns whom you are training for your community medicine, I am from a community medicine department, so we have at any given point of time 20 interns, 4 PGs, 3 probably assistant professors or lecturers in the area who are providing care. So if at all, if you are able to link it, the primary infrastructure, because in most of the other models, we will be required to identify the remote end. The problem is not with the tertiary care hospitals. Every hospital is ready to link because they will feed your hospital. It is the remote end which is the problem. The quality of the remote end physician, because we are talking about RMPs, if we cannot replace them, we cannot shout about them. Because they are the ones who are providing care in many places. So enable them, empower them with this. So that is what we are saying. So you have the trained manpower at your remote end, and also you have a cost-effective utilization of scarce resources. What are the scarce resources? A CT scan machine cannot be put in Kaivara, the place where I go, as a rural training center. The cost economics, no administrator will ever put in because the volumes are not sufficient. But does that mean that a tubercular meningitis in a rural area does not require CT? Absolutely not. So where do we go? Link it. If it requires, bring it in here. Feeding the teaching college hospitals. Today, the problem with medical colleges mushrooming up. In Bangalore, we have 7 plus 3 coming up. Tuberculosis case will be a rarity. Not necessarily in India, but that situation will happen. Wherein the common cases which we think that by looking at the patient, my professor could identify that this is a case of something. Because that was the infectious disease load that they were bearing. But today teaching hospitals lack the critical load which can be brought in, because they are the patients who need to come in by enabling this kind of a cross-linkage between the teaching and the center. So coming to our college, just 2 slides I'll be telling like why. Because this will be the profile of most of the colleges. Number of seats and all those things, either the seats can vary between 100 or 150 with the equivalent proportion of postgraduate thing. Why these numbers become important is, just look at the manpower. We are complaining of inadequacy of manpower, so we have the manpower. 100 PGs doesn't mean that it is a small number. Multiplied by the number of years and the number of DNBs and other things, it is a huge number. Why are we not utilizing them? Isn't technology available today? Because from morning every stall is saying that look, we can do this, and they have done it. Where does it go? Plug and play. Where do you plug for it to play? This is the place wherein you need to look at it. Faculty strength more than 300. These are all highly trained, skilled professionals with so many years of experience, because a professor should have 10 years experience. So you have a trained manpower, trained skill. De-skilling is not required. These are all skilled professionals who are there in all these medical colleges, 375 plus into this number. What is the number of professionals we are talking of? That is the point. And The problem is, even for a medical college, it is not just charity. Each medical college, from a private medical college, I know if I have to get my salary, the revenue has to come in. With the regulation of the medical colleges, number of seats, common entrance test, there is a problem. The seats cannot be sort of like capitation fee and other things. Let's be practical. So where do you get your patient load from? So that is also a thing which will enable you spread out your wings, get the patients, and there is a win-win situation to both of them. So the cost effectiveness of this model will automatically be built in. So coming to the teaching hospital, that was the college, but the hospital, within our hospital, we have certain inherent advantages which will be there. I'm not talking about only Ramaya, the name you can just block it. It is a teaching hospital. Any teaching hospital, there will be a subsidy. There will be a reduced OP cost. In fact, in our hospital, we have a 50% reduction, and for the rural area from where we get the cases referred, it's completely waived off. So the point is, your cross-subsidization of the cost can happen automatically provided your volume increases and you have a corporate wing. Like we have a corporate wing, the Memorial Hospital is the corporate block of the teaching hospital itself, wherein the luxury is provided. It is like a darshini. I don't know, some of you who might have been in Bangalore, there is a place wherein you get the same idli which is, or the breakfast which is prepared in the same kitchen. If you are standing and eating it, it's 10 rupees. If you are sitting in an AC room, it is 50 rupees. Same quality. We are not talking about low cost does not necessarily mean low quality. So we are talking about high quality or same quality care doled out. If you want an AC, you got to pay for it. Point. So in that sense, like each teaching hospital, it's not just Ramaya, each teaching hospital can have this duality of cafeteria approach, wherein the high-end paying patients can buy the care, the same can be given to the patient in the remote area using the technology which is available at a low cost. Secondly, the cross-utilization of high-end resources. If I don't run my auto-analyzer at 60% efficiency, the cost of a thyroid stimulating hormone test is 2 times what it would cost otherwise. My pricing largely depends on volumes. Where do you get the volumes from? This is the place to bring in the volumes, because this is all high-end technology, so we have to marry the technology for the thing. So in fact, the title was low-cost technology and use of low-cost healthcare for use of technology. So you can get in your volumes, thereby the cost automatically drops down. Then having this HMIS, again this is a technology which is an enabler. E-health records we are talking of. You are creating population database, especially in a teaching college model. In our rural field practice area, 2 PGs will be required to do a dissertation or a thesis. It is mandated in a medical college. The moment they do a rural thesis, you are having a sample size of 40 to 50 households with so many number of people. So your e-health record is built. That is the population health record for the whole area, wherein you can do all your predictive analytics. Who might be at risk for developing this disease, and you intervene. We are talking about the spectrum of care. Health is 4 components: preventive, promotive, curative and rehabilitative. This entire thing, the spectrum, unless we address all the components, health we are not addressing, we are addressing only the disease. And technology is not only for the disease. So the preventive and promotive component, which is not so very thoughts are given into it, for the simple reason that it is not cost effective. So towards that end, what model we are proposing, or we are actually having at Ramaya, is like we are trying to utilize the high-end resources at the hospital to reach out to the public or the masses in the rural area. And we have also developed certain advanced systems so as to cut down the cost within the hospital. It could be our in-house packs. This was developed by the radiologist within the Ramaya hospital, wherein the cost of printing an X-ray and all those devices has been cut down. So advantage again is like we are having a digital X-ray at the remote end, which can be read by radiologists sitting in the hospital, because you have at least 6 radiologists, qualified MD radiologists for 1 PG seat in MD radiology. So towards that end, you are utilizing the scarce resource for the remote end with the best quality of care. And this is the profile of the subset of what I am talking about, the Kaivara, which caters to 20 to 30,000 population. And any medical college will be catering to this. Into 375 is what we are looking at. So, and this is the last slide. Apart from this, can we use this network for something else is the question. Because healthcare does not limit to only treating the patient alone. Training, research, advocacy. These are the other three components which will be ingrained into any of these things. So, you can use this for teaching and training of postgraduates. Mr. Sir was just telling, Lucknow and all the premier institutions today have a common kind of a PG training program wherein you can plug and play with all the best of the best teachers can interact with the students. So you can just enable that. If you just imagine the kind of power we will have if you have the entire medical colleges with the best of the teachers in one single circuit. That is the power. Training of paramedical workers. Again, we have ASHAs, USHAs, all kinds of under the NRHM banner. Where do they get trained from? So you have the best teachers who can train them for all the skills and other work. So that is one of the things. Then monitoring of national health programs. More than 70 to 75 programs are being implemented by our department or any community medicine department of a premier institute. How do you monitor? Use this telelink. You can use the entire set of e-records and other things for your surveillance and monitoring activities. And finally, conducting CMEs and symposiums for private practitioners. This is the thing. The moment they are not threatened, the moment they know that the private practitioners of the area know that you are not going to cannibalize into their private practice, they will be more than willing to come and jump into your network more readily, and they will refer all the tertiary cases. Because as they told, 80% of them require primary and secondary, only 20% tertiary which your institution can offer. So this is the model: low cost, use of technology and practical. So thanks a lot for the opportunity given. Thank you.